Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is James Ferrie, a musculoskeletal podiatrist from Australia. James came on the show back in season 3 on episode 8, and I wanted to bring him back today because he is really a world-class leader in diagnostic ultrasound to talk about complex heel pain, which is an interesting and ever-challenging subject for anybody who is in this arena that has to treat complex heel pain. So please enjoy my conversation that I have with James Ferrie.
All right, everyone. I am here with James Ferrie, and he's coming to us today. Actually, tomorrow, or today. It kind of always messes me up, the time difference between Australia and here. And I guess there was a little change even in the recent last week or two. You guys changed time again? Or
there
something?
was. We went. We went back an hour for daylight saving. So just to throw another spanner in the works with the 14-hour time zone difference.
Exactly. Well, James, thanks for coming on. I always love looking at what you're doing. I think you're one of the best sonographers I've seen, and I always learn when I look at your things. And so today we're going to talk about complex heel pain. And
thanks, Stephen. Appreciate being back on.
Yeah. Let's get into it. I think we wanted to talk about fat pads today, right?
Yeah. I think I think fat pad's something that I didn't appreciate very much at the start of my career. And ultrasound's something that I've used in clinical practice now for the past decade. And I think when I first introduced ultrasound, it was primarily, I don't think I appreciated how valuable it would be in practice. It was more, I was looking at it from a ends to a means, where I'm looking at, I was doing PRP at the time, and it was more, I wanted to learn how to do ultrasound guided injections. But I think what's probably been the most valuable development is how useful a modality it is for assessing chronic heel pain and assessing a lot of the chronic conditions that we see. Because patients will often, with these sort of complex conditions, come in with a bag full of MRIs, X-rays, CT scans, bone scans, a whole range of imaging modalities. But ultrasound, I think, is primarily really a first-line approach. And I think as clinicians, we use ultrasound differently to a sonographer and a radiologist, where ultrasound is really popular as an imaging modality in Australia, where we will refer someone off for a musculoskeletal ultrasound for their plantar fascia, but they primarily will work through a worksheet. So in order to get the item number for a hindfoot ultrasound, they've got to go through and check off this tendon, and then you'll get a pretty brief report that might say something like, that the plantar fascia is thickened to 6 millimeters with a hypoechoic appearance. Now, that's probably not the most useful information, but having point-of-care ultrasound in practice really gives you the ability to look at a whole different, we can look at the osteology, the calcaneus, and that can give us an idea of some of the compressive loads that might be contributing to the heel pain. We can look at the integrity of the fat pad. We can also look at the fascia, and we can even grade, like you've previously described, whereabouts the fascia is degenerative, because I find that if it's more so under that right directly under the calcaneus, that infracalcaneal area, we probably need to look at more the compressive loads compared to where it's more distal in the traditional area where we measure the plantar fascia, which is sort of just distal to its insertion.
Right.
And we can also look at things like the tarsal tunnel. So we can look for any space occupying lesions. We can assess the neural structures and also look for things like fatty edema in the intrinsic foot muscles. So I think we get a lot more information, and ultrasound comes in as almost an extension of our clinical exam,
Right.
as opposed to a standalone imaging procedure.
Right.
You know, I go into ultrasound, into a scan after I've already taken a very thorough history. And, 80% of your diagnosis is in your history. A patient primarily will tell you, if you listen hard enough, what's wrong with them.
Yeah.
Your clinical assessment is really to further work on that and to either confirm or to falsify some of your hypothesis. And then ultrasound gives you a whole nother ability where you can get a window inside the human body and to assess some of those structures. So sometimes not finding something is actually even more useful than finding something. So like an example of a case I just saw very recently was a lawyer in her 40s. She took up walking and decided she's going to walk 12 kilometers in the first day. And she tried to do it the second day and couldn't walk any further. And both her parents are physicians, and she came in saying, I've got plantar fasciitis. Within 5 minutes of putting an ultrasound on, you could see her plantar fascia is pristine, her Achilles is pristine, but she ended up having a calcaneal stress fracture. So being able to rule that out as a diagnosis very quickly was really helpful in order to get to where we need to get to from a diagnostic point of view first up.
So I think you make a great point there. I started really implementing ultrasound in about 2000, maybe 2001. And, people had been talking to me about it for like 5-6 years before that. It's like, no, I don't need that, and then all of a sudden you start utilizing this and you build up this experience with it, and you're starting to pick up all of these things. It's pretty incredible. Not only what you do find, but what you don't find, which I think is a very valid point. But also, it gives you the ability to look at the plantar fascia and determine the severity of it and make then calculations into your treatment plan for these patients in it. And I would and this will probably get me in a lot of trouble, but I would say that anybody who considers themselves an expert in heel pain that does not routinely use sonography is disingenuous. They're just not the real deal. How can you press on something with your thumb and get an idea of what's really going on?
I completely agree. And I think one of the things we see in the literature is the terminology's changed quite a lot over the past few decades. So from plantar fasciitis to plantar fasciopathy,
Right.
to sort of describe more of the degenerative change. And now there's been a shift to just talk about chronic plantar heel pain, where I guess in one element they're saying that, well, we're taking into account that it's not just one tissue that is always primarily driving. So in someone with plantar heel pain, it's not always just the plantar fascia that's driving the pain. But then from a clinical point of view, that's actually not very helpful for us as clinicians, because it doesn't help us work out, are we dealing with nerve pathology, we're dealing with bone pathology, we're dealing with fascial pathology. Now, there's always going to be an overlap between all of those things. And when you just press with your thumb, is it the fat pad that's tender? Is it the plantar fascia that's tender? Is there a bit of subcalcaneal bone marrow edema that's tender?
Right.
We can't really differentiate or work out what's contributing, but I think that visual representation and that window inside the human body, and like you said, the more you use, I had an underappreciation of how much it would change my practice.
Right.
And I can't practice without it now. And I agree with you. Anyone who considers themselves an expert in heel pain that's not using clinical ultrasound, I think is missing a significant portion of what's walking through their door.
Well, to me, it's like the astronomer who would never look through a telescope.
Yeah.
I mean, it's just...
And it's It's a cost effective modality. It's cost effective. There's no ionizing radiation. It's very quick to perform, and it's also dynamic, which MRI has. Look, MRI has a much better contrast resolution between the different tissues. Bone and fat have a very different contrast on MRI. But from a spatial resolution point of view, how many pixels on the screen represent the plantar fascia? Ultrasound wins out significantly, but it also gives you the ability to dynamically assess something. So particularly when we look at something like fat pad pathology, you can't accurately assess the functionality of that fat pad on MRI. You can see some changes when the fat pad's degenerative on MRI, where you might see some sort of fibrosis, you see some diffuse high signal within the fat pad, but it's difficult to actually visually assess what's the integrity of the fibroadipose septa in the fat pad, because primarily I think in some of our younger patients that have pathology of their fat pad, it's not so much a loss of the fatty tissue, it's the connective tissue that creates the cells that holds that fat underneath the heel can deteriorate. So when there's dynamic pressure on there, all of a sudden that fat pad parts, and you end up with this situation where you've got the fascia and the bone effectively resting against the skin. So it's no longer got that sort of protection. So the ground reaction forces significantly increase, and that puts a lot of, and I think the plantar fascia is a bit unique in most, if you consider other, not that the plantar fascia is a tendon, but if you consider other tendons, they're not weight bearing. Whereas the plantar fascia is a different structure that actually has to deal with both compressive and tensional loads on it as well.
Well, one of the things that I learned many years ago, probably didn't learn it soon enough, was that the constituency, the cellular makeup of the human plantar fascia, its cross-linking is a little bit different. And so it actually has a hydraulic ability in and of itself. So these fibrils can actually separate and contract back and forth. And I think that's what renders it more susceptible to some of the degenerative pathology that we see because of this dynamic nature of the fascia itself. But I want to get back on something that you mentioned, because not only is it imperative in diagnosis, in my opinion, and it sounds like in yours, that to have sonography and really get an idea of what's going on with the tissues, but it also gives you a great ability to assess regenerative treatments that you're doing. So you can sequentially look and see how are these tissues responding. And it's not only the plantar fascia, but we're talking about plantar fascia now. So let's talk about it kind of specifically. But let's say you come in with a 7mm fascia, and we categorize different zones like zone A, zone B, and zone C. And what you talked about directly inferior to the calcaneus, we call that zone C, C for calcaneus. And we found that, that's a harder one to treat than if it's more, a little bit more anterior. But what's nice is that you can assess these different areas after you've given some type of a regenerative treatment, whether it's PRP or amnion, or I personally love BPC 157. So you can see, all right, wow, 8 weeks ago, this fascia looked totally different than it does today. So yeah, patient may still have some pain because their symptoms, as you well know, don't always correlate to the status of their imaging. Sometimes they'll lag a little bit behind. You can at least tell them, listen, you should get better because this tissue is getting better. And so I think it's really valuable from not only a diagnostic aspect, but a prognostic, as well as how are we doing with the treatment down the line.
I completely agree. I use ultrasound very much so to, I guess, understand the degree of pathology, because it changes the approach that I take. What's more common is this sort of protocol-driven approach to managing, say, heel pain, for example, where patient comes in and they have to go through so many weeks of stretching and exercises, and then they go and they might get an orthotic, and they might get extracorporeal shockwave therapy and so forth. So some patients that you see have actually already spent, well over $1,000, thousands of dollars on treatment, and have not got any real outcome with that. So being able to assess, for example, is there a tear in the plantar fascia? That can be really, really helpful. Is there some sort of nerve-related issue where there might be some neural compression going on through there? That really helps to differentiate, because what I typically will do is if I see a patient who comes in, and this is the approach that I generally will take, if there's quite significant degenerative change of the fascia, but there is no sort of no significant delamination tears on ultrasound, and there's no significant intrasubstance tears, I will often use extracorporeal shockwave therapy as more of a first-line treatment if they don't have a significant mechanical history. So if I see someone who comes in and they've worn orthotics for decades, they've had, problems with knee, problems with lower back, and there's a really strong indication that there's something mechanical going on there. In those patients, I'll often address the mechanics first up. But if I see a patient who comes in and they might be, 50 years old and they've really never seen a podiatrist before, they've never experienced sort of chronic lower limb pain, and there's more fascial degeneration where we don't have an actual tear in the fascia, I find that those patients will often respond quite well to extracorporeal shockwave therapy. And I use a combination of focused and radial in practice. But for the patients who have a significant delamination of the fascia, so that degenerative change is more advanced, or there's an intrasubstance tear, and these patients sometimes present with that really acute on chronic presentation. So they might have had some heel pain that was very manageable, very classic first step pain first thing getting out of bed. Once they get moving, it sort of warms up a bit. And then all of a sudden, they might have been managing, and it might not have even been something that's taken them to see a doctor or a podiatrist or a physical therapist. And then all of a sudden they get this massive escalation in their symptoms where they're having difficulty weight bearing on their heel. Their symptoms are now persisting through the day. It's very common in those cases where you put the ultrasound on and you see that there's a delamination tear or there's an intrasubstance tear. And then you do get this acute flare. You actually do see some mild edema in the fat pad and in the perifascial tissue as well. So you can have a degenerative pathology that also has a bit of an acute flare in pain. And I think it's probably much the same as someone who has, say, degenerative knee osteoarthritis, who ends up with a more of an acute meniscal tear. Even though there might be some chronic meniscal tears and degeneration in the joint, when you first injure that tissue, you get some granulation tissue. It will cause an increase in inflammation. And even if the meniscus itself doesn't heal back together, eventually over time, the torn area will effectively fibrose or scar up, and the swelling and stuff settles down. So even though plantar fasciosis is degenerative in nature and not so much inflammatory, you can see these inflammatory flare-ups in these patients. And in those patients, I find that they do tend to do much better with a regenerative injection, as opposed to having to persist with things like, orthotics and stretching and exercise, because those are the patients I often see after, and they're very frustrated, and they're often at that point quite emotional because they've not made any progress in terms of their approach. They've got a pro forma exercise, some plantar fascial stretching, some exercises to do. They might have had some advice on footwear, but they're otherwise not improving significantly. Those patients I find tend to do really well with a regenerative injection. And being able to, I guess, work out which patients are going to do better with that versus something else is just, it saves the patient a lot of money. Poor care costs the patient a lot of money. So ineffective treatment and not understanding, if the clinician doesn't understand all the factors that are involved in that presentation, you can waste the patient's resources and money on treatments that are ineffective, that are not likely to help.
Well, but this speaks, what you're saying right now, this speaks to the dogma of the old orthopedic literature that says you have to treat this for a minimum of 6 months to a year with conservative therapy and all of this other stuff. I would make an analogy. It's kind of like a little tiny fire in your house versus half of the house is burning down. They're both fires, right? But are you going to treat that little fire like you're going to treat the fire that's consumed your whole kitchen and one of the bedrooms? So it's absolutely ludicrous, even in the medical legal arena up here, where people will say, well, they didn't exhaust conservative care. Well, that's total bullshit, because they may have a fascia that was so degenerative, all of that stuff would never work anyhow. And so you're just wasting this poor person's time, keeping them in pain, lots of ineffective therapy. That's why, again, we go back to the sonography tells you how big the fire is. Oh, it's just a little tiny thing by the electrical outlet. Oh, well, great. Then if that's the case, you're stretching, your, other modifications, insoles, whatever it is you want to do, they're likely to prove very effective in those cases. So it's 2024. If you're not using an ultrasound and you're managing heel pain, you probably should be taken out back and, by the woodshed and be whipped a little bit. And I'm really having to censor myself now because I really get irritated about, there's so many people I see that they'll come in and they wild stuff, right? They had a mag of 6 pairs of orthotics. They have had immobilization for 6 months where they were told they have to stay in a cast and all this other stuff. And no one ever looked at them with an ultrasound. It's like, well, how do you know what you're dealing with here? It's mystifying. Let's circle into the fat pad a little bit, because one of the things that people love to do is inject these heels with steroids, which I hate. But you're going to get the fat pad atrophy. I mean, I've had patients that have had, 30 steroid injections over a period of time, and they have skin on bone. They have no fat pad whatsoever. And then you'll have people that will have maybe 1 or 2, and that they'll get what we call kind of a diastasis, where I think that's where you're talking about these fibers septa, where they just get separated apart. There's some kind of damage to it, that type of thing. Well, then that blows the whole hydraulic mechanism of plantar fascia. So let's talk about what you found with that, and the dynamic ability of what you're able to evaluate with the ultrasound in dynamic things.
Yeah, look, I would completely agree, and I think we've known for a long time steroids are being used to treat heel pain for 70 years or so.
Right.
It's not like a new treatment, and we've got very high level evidence. You've got Cochrane review, meta-analysis level of evidence that steroids temporarily or up to 4 weeks improve someone's symptoms, but after 4 weeks they're no better than a saline injection when we compare them. And I think there's been about 11 randomized control studies that have looked at steroids. And I completely agree. We see, and I think this is the difference as well. When a clinician's not using ultrasound, they also can't see the damage that's caused. So if you're not using ultrasound and you're delivering steroid injections, you can't assess, you don't know that the heel fat pad, and most of the patients that we see with these fat pad pathologies, or who present with heel pain, have some degree of fat pad pathology as well. I think it's a big predisposing risk factor, because we see patients that may not have heel pain that also have degenerative changes in that fat pad, where the fibroadipose septa have started to break down, or there's some atrophy of the fat pad. And I think there's probably 3 cohorts of patients that I think this affects. It affects your fit, healthy runners, the long distance runners, that repetitive pounding of the pavement. So I have some patients with significant fat pad pathology that are otherwise like healthy women and men in their 30s and 40s who have just done long distance running for a decade or 2. The other population you'll sometimes see is in the obese and the overweight. And the third is the steroid patients that have had repeated steroid injections. And I think I do have, Stephen, I've got an ultrasound image of someone who I'd recently assessed their fat pad. And I think it's probably powerful to see that sort of visual representation. I'll see if I can.
Yeah, let's see that.
I'll see if I can share my screen.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBARRETT at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
So in this patient here, I'll just, what we can sort of see is it's a dynamic image. I'm looking at the calcaneus here. So this is a short axis. So we're looking at short axis of the plantar fascia and the plantar heel. So to orient ourselves.
James, is medial on the left or the right?
We have, I think we've got medials on the right over here.
Okay. Just
Okay.
here it is.
So, yep. So what we're basically looking at is we've got the skin up the top here. We've got the micro fat pad, which is the sort of smaller. I typically don't see many problems with that micro chamber, but the fat pad has effectively two chambers to it. It's got the micro chamber, which are the smaller fat compartments that sit against the dermis. And then we've got the macro chamber through here. We've got the calcaneus, and we can see it's the calcaneus because you've got that nice echogenic, bright, bony cortex with acoustic shadowing because the ultrasound can't penetrate through that. And we've got the plantar fascia here. And in this case, the plantar fascia in that C zone or that inferior calcaneal zone is very thickened. And you can also see that it's quite delaminated as well. It's got a really heterogeneous appearance. It should be nice and consistent. Now I'll show you in sort of dynamic, this gives you a better idea. You can see this is me just compressing it. And you can see how there's effectively a full thickness defect or that diastasis in the fat pad. So there's really a full thickness tear between the fibroadipose septa. And you can see with compression, that fascia is resting up against the micro chamber and the dermis through there. So in this case, the patient has quite significant fat pad pathology that is contributing to the heel pain. Although we've got fascial degeneration, and you've also got a change in the bony osteology. You can see how irregular that calcaneus is as well. Mm-hmm. That in itself is really just a representation to me that there is compressive loads that are contributing to this presentation as well.
Now, are you making on your routine evaluations, if you think there is fat pad pathology, are you making measurements and like a compressed measurement versus a non-compressed to see the...
Yeah, and look, I think there's crossover. There is a degree of crossover because I don't think they're going to be purely compressive or purely sort of tensional, but there's some degree of crossover. In something like this, I think the way that it changes my approach very slightly is these patients do not do well with a rigid orthotic, a rigid, hard polypropylene orthotic underneath that heel. So I'll tend to use softer materials.
Right.
If I'm using something like that, they tend to do quite well in more of a maximalist type shoe. So things like the Hoka or even the new version of that have more of a maximalist sole to it. Right. So particularly these patients don't do so well with very sort of flat, flexible, poorly cushioned shoes. So that's just something. And when I use an orthosis with these patients, it's typically something that's a bit more sort of softer and accommodative, just to try and reduce the plantar pressure. In this case, I also did a regenerative injection. I actually just used traditional prolotherapy or some dextrose, so about a 12.5 to 15% dextrose, because she had a non-healing tear that had been there for I think about 8 months by the time I'd seen this patient.
Okay.
So this was again a bit of a complex presentation where the fat pad pathology was, and when I compared her contralateral side, there was also degenerative changes of that fat pad as well. So it's not, in her case, I think there was degenerative changes that again probably predisposed this presentation. So she went on a big long distance hike with some friends that she didn't train for. And day two, her plantar fascia developed tear. And when I saw her back, she'd had this sort of chronic tear in the plantar fascia.
Now,
But what's,
let me ask you a
yes, go
question,
ahead.
because I think this is a great illustration as far as the inferior surface of the calcaneus. Have you noticed that like if you take these short axis views from posterior to anterior, that some people have what I call the perfect crescent all the way along, and then there are other people that will have this almost like a tubercle, not an exostosis, but it's like an irregular, or it almost comes to more of an apex rather than having a nice smooth convex surface. Have you noticed that in some of your patients?
Yeah, I think it plays a huge, I think it gives us an insight into, I think that appearance of the calcaneus and the shape, and I think this is that whole argument around sort of plantar heel spurs. We know that plantar heel spurs are not necessarily a large pain generator, but it does give us some insight into the adaptive loads, because the plantar heel spur developed in response to loading
Right.
of the calcaneus,
No
right?
doubt.
So it's an insight into that.
Right.
And I think that looking at the shape of that calcaneus, it does help, because in someone like this, where you've got this very irregular there's often some sclerotic change in the bone, and on an MRI, we'll often see in those more acute on chronic presentations some degree of subenthesial bone marrow edema. And I think that's important because it does take longer for that bony pathology to settle down, in combination to say more of a purely. So if I'm doing extracorporeal shockwave therapy on someone who likely has some subenthesial bone marrow edema or swelling in the heel bone that's basically at the attachment site of the plantar fascia, they take longer to settle down. They still settle down, but they do take longer to improve compared to someone without that.
Okay, let me ask you this now, because I want the audience to look at this. And if you're just listening to this on the audio, I would highly recommend that you go to the YouTube and look at it, because it's a fantastic ultrasound illustration. So very clearly, we know that there's a lot of degeneration in this plantar fascia that can probably be taken care of pretty well with your prolotherapy, your regenerative therapy, whatever you want to do with it, albeit not steroids. But how do you address this diastasis that you're seeing in the fat pad? Is that strictly by orthotic modification and floating, or are you doing anything regenerative to try to help this fat pad?
It's really interesting. What happens when you do a regenerative injection in these patients is inevitably the regenerative, the injectate that you use floods this space anyway, because there is a and you see this when you inject the plantar fascia. There's effectively there is this connective tissue that separates the fascia from the fat pad. And when you inject, you almost see this separation of those two layers, right? The fat pad actually almost lifts nicely away from the plantar fascia. In someone with this degree of pathology, their fat pad, there's a defect in that. So when you inject, all your regenerative injectate also floods into the fat pad as well.
Right.
So I think that some of it gets in there. I'm really not sure with these patients. This is something that would be really interested. I'm interested in following some of these patients up to see whether this is something that repairs over time. I have a suspicion that the fibroadipose septa, when they're injured and when you've got this degree of injury, I'm not sure how well this heals up. And I remembered the podcast you did with the husband and wife team that were addressing some of the fat pad pathology. I'm really not aware of anybody in Australia who's treating, and I think that might be one of the difficulties in addressing fat pad pathology from a say from a transplantation type intervention where you take fat from another area and you inject it underneath the heel. It's not so much that in this case, when you have a look at the compression, she has fatty tissue under the heel.
Right.
The problem is the connective tissue that creates that hydrostatic force of the plantar fat pad, that's been damaged. So the fat pad's effectively squishing medially and laterally when the patient weight bears. And I think that this also does contribute in particularly patients that have a higher BMI. As that fat squishes out from underneath the heel,
Right.
it effectively has to go somewhere. And it increases the compressive loads on the medial and the lateral tissue. And particularly, I think the nerve that tends to, sometimes you have trouble with that is the medial calcaneal nerve, because that tissue almost squeezes into that location. And in patients that have that high BMI that also have some fat pad pathology, I think it's not uncommon for them to have some degree of almost like a nerve, some degree of mild neuritis of that medial calcaneal nerve. And I suspect that some of that's coming from the fact that because the fat pad's being displaced so much, it creates almost compression on that nerve.
Well, I agree with you on that. I mean, I personally think fat pad defects are extremely difficult to treat because it is a tissue. I think it was Knack and Phillips way back in the early 90s that made a point that once these fibrous septa are cut, they do not regenerate. And that's why open needle surgeries are so devastating to the fat pad. Because, and then the other thing is, I don't think the fat pad is revered as much as it should be. I mean, it is an incredibly complex hydraulic mechanism that essentially keeps our brains from rattling around in our craniums. Like you could imagine you would, if you had a golf ball in a mayonnaise jar and you shook the jar around. Without the fat pad, that's kind of what happens to the whole human skeleton, all the way up into the head. So it's a super important structure, but it doesn't get recognized as important as it is. And B, once you do recognize it, then what the hell do you do with it? Because it's not an easy thing to take care of. I mean, some people will try to imbricate it, bring in, some sutures and try to pull that fat in underneath the calcaneus. I've even had a very, not often, but actually I had a patient who was a general surgeon that had like 20 or 30 steroid injections. He had zero fat pad. His calcaneus was literally 1 millimeter from the dermis. There was no way the man could walk. He had weird osteology. We ended up doing a partial calcanectomy on him in order to just try to get some soft tissue under his heel. So it's a hard problem.
Yeah. And what I've also got, I can show you, I've got a patient here. This is a younger patient. It's really helpful with these fat pad patients that have fat pad pathology to also look at the pressure analysis. So pressure analysis as they're walking as well. So this patient here, she's actually a young patient in her 20s who had torn her plantar fascia with long distance running. She was increasing training for a marathon and developed a tear in the plantar fascia. Right. She was initially, and this is a good example of, I guess, management that's been maybe suboptimal. So initially she was seen by a podiatrist. There was no imaging that was done. She was prescribed some orthoses that didn't help all that much. Then when she finally sort of was demanding that I'd like some imaging, an MRI was ordered, which showed there was a tear in the plantar fascia. They then immobilized her for 12 weeks. And when she came out of the boot, and this is I think, like you mentioned before, I was reading an article and they were talking about really the metabolic rate of fascia and tendons. And they're very strong tissues, but they're relatively avascular and they have a very low metabolic rate. So their capacity to repair when they're just deloaded is just not the same as, say, bone or muscle. So if you break a bone and it's in reasonable alignment and it's reasonably immobilized, the tissue is quite vascular and it will heal up quite well in most cases. And the same with muscle. If you tear muscle, it generally heals up and scars up quite nicely. Fascia, on the other hand, this patient came out of the moon boot, out of the cam boot after 12 weeks, and although when you're wearing it, there's less pain because you're not walking on it as much, there was really no improvement overall in her symptoms. So then she was referred to a surgeon. They did 3 steroid injections, and then the next step was doing a fasciotomy. And this is a young lady who's in her, should be about 28. She really, at this point, she's not overweight in any way. She just has a chronic tear in the plantar fascia that wasn't healing. Now, when I had a look at her, if you look at this pressure analysis, I'm sure just looking at these curves, so each of these little boxes here represents a line on the curve. So I can look at the pressure on this axis versus time. And if we have a look at the medial heel particularly, you can see on the right side, it's about a third higher than it is on the left side. But you can also see the rate of loading is different as well. You've got a much steeper curve, which suggests that the loading rate is higher. And if you see on the left side, that hydrostatic function of the fat pad, it creates a really nice smooth loading pattern on the heel. Whereas you can see how the loading pattern on this right one is quite irregular. The loading rate's higher, and the peak plantar pressures are also nearly a third higher. So you can see that sort of functional difference that the actual fat pad makes. And I think in this particular one here, what we're actually looking is the loading rate. So we can see the loading rate of either we've got different lines that represent different areas of the foot. So if we look at the medial heel, for example, on the right side, we're looking at the loading rate in newtons per second. So at heel contact on the right, would be about 2,500 newtons per second versus 1,800 on the left side. So again, a significant difference in terms of the loading rate. So in this patient, when they make heel contact, the rate of loading is much higher on the side that had the pathology in the fat pad. So this gives that sort of biomechanical data of the effects that pathology on the fat pad has on the underlying tissue that we're dealing with.
Now, what would you attribute that increased loading rate to? Would that be a limb length inequality? Would it be something proximal that's going on that isn't going on the left side? What's your thoughts on this particular patient?
I think it's the reduced. In this case, the patient doesn't have a leg length discrepancy or anything like that. Okay. I think it's the reduced attenuation properties of the fat pad because of the pathology. This patient had 3 steroid injections and there was significant degeneration of their fat pad. So if we just look at, and because it's a 28-year-old healthy female, the fat pad on the contralateral side on the left side was completely normal. So you've got that really nice, you've got this really nice curve. If you look at the heel loading rate at heel contact, it's a nice slow loading rate and then it drops off as they move into mid stance. You can see on the right side, we get a steeper loading rate, but it also is more irregular. And I think that's because of that loss of cushioning and that loss of attenuation properties of the fat pad. We have higher loads on the calcaneus and the tissue of the plantar heel.
No, that's fascinating.
That was the only thing that's the only thing I could attribute in this particular patient to what was contributing to her issue. The good news is that once we healed her split and tear in the plantar fascia, it's now been probably 12 months. She only works around the corner from my clinic, so I bump into her all the time at the coffee shop. And she's back running now, and we've got a combination of things. So the tear we addressed with dextrose prolotherapy, and in the past I've used PRP as well, but I've actually probably shifted back to using dextrose a lot because I just find it really easy to titrate the response. I found sometimes with PRP that you could sort of stir it up in a significant way in some patients. So there was a bit of variability, but she did really well with a regenerative injection. She's actually back running. She's got a nice sort of accommodative orthotic to assist somewhat with the fat pad pathology. And the tear, we actually re-ultrasounded her tear just for interest the other day, and her plantar fascia has regenerated really nicely. It looks almost symmetrical to the other side.
It's very easy to see how this inferior calcaneal fat bed can become pathologic just when you realize how much pressure force is put through that area 10,000 times a day, however many steps they're taking. It's really amazing that we don't have more problems with it.
I agree.
So, no, it's fantastic. I think you make a point here with this is that even though these are considered focal pathologies, they're not really focal, they're global. There's a lot of things going on. You know, we talked about limb length. Is there something going on with their morphology? I just had a real good friend of mine came in just a couple of days ago with bilateral plantar fasciopathy, and I had treated his left heel probably about 10, 11 years ago with amnio, and his right was really very, very, let's call it symptomatic. His left had some symptoms, but not near as much as his right. And in the ultrasound evaluation, what was really interesting was that, yeah, on the left side, he did have some increase in the thickness of the fascia, but there was no hypoechoic signal intensities to indicate any frank degeneration in that fascia itself. But he had this weird looking inferior calcaneal surface, whereas in the right, which was the current problematic side, he had a perfect crescent there. So my experience has been that if I see that irregular osteology, it's usually symmetrical. They'll have it bilaterally. It may not be the same, degree, but if one may be less than the other, but they have. It's not just a nice crescent moon. And there really hasn't been much written about this, I don't believe, as far as what this surface is doing. But if you think about it like a cylinder that's it's rocking back and forth from supination to pronation back to, back and forth all the time. And then we stuck a BB or something on this cylinder. Every time that cylinder would roll and hit that BB, you could see why it would cause this degeneration that we see. So I thought that was a very interesting thing. But I think you point out there's a lot of considerations here. What caused this fat to go bad in the first place? Was it iatrogenic from steroids, or was it just a runner that was overusing things? There are lots of considerations going into this.
It's a really, really interesting point, and I agree with you. And this is, I think, throwing the baby out with the bathwater when it comes to plantar heel spurs, because plantar heel spurs are effectively just a change in the osteology and a bit of a shelf of bone that grows from that medial calcaneal tuberosity. What's really interesting is that you would know as well that when you see a intrasubstance tear in the plantar fascia, I would say that about 90% of them are against the leading edge of that irregular bone. So they're the deep insertional side of it. And I think that it's exactly that. It's that when the foot's functioning, you've got that natural rolling effect where you've got that nice sort of that nice sort of convex surface that creates a bit of a cylinder as we go from sort of heel to toe. And what I think you end up having is when you've got that irregular bone, it's not so much that the heel spur is generating pain, but the pressure that it places on the plantar fascia contributes when you've got degeneration. That's a very common location for where it tends to tear.
Yeah, I think, a real good, I know you're probably familiar with Leon Muehlen's publication. I think it was probably about 2008, where they looked at the trabecula in the inferior calcaneal exostosis, and it is an attraction appendicitis. It's clearly, basically, the way I think of it, and I don't even like to say heel spur syndrome, because I think the spur is a physiological response to increased pressure in the area. This has definitely, it's a mechanism of guarding against high pressure area. I mean, if you think about it, if we're able to lay more bone down and spread that pressure over a larger surface area, that's going to be advantageous. But the spur got horribly villainized as the end all be all for heel pain. And when we first came out with endoscopic plantar fasciotomy in 1990, they were saying, well, you got to cut the spur out and all this other stuff. And the answer was, no, you don't. In fact, you had a lower success rate if you cut the spur out with the fasciotomy than if you just did the fasciotomy or fasciectomy. And I think the reason people got better when they had a heel spur resected was because to get to it, they had to cut the plantar fascia. So it wasn't that they were doing anything with the heel osseous pathology, but man, they love to look at that on the x-ray. And here's the Mrs. Jones, look at how big this heel spur is on this one. And now we took it off and you got really clean, smooth calcaneus, beautiful. And the poor patient wouldn't walk for a year, but boy, their x-rays were fantastic, right?
I think that's yeah, spot on. And I think it's probably only been in the last 20 years really that diagnostic ultrasound and even MR has been as accessible as it is. And prior to that, an evaluation when you saw either your primary care physician or you saw a podiatrist or you saw a surgeon would have been just an x-ray, and a lot of decisions would have been made off that. And like you said, it's a glaring change in the osteology of the bone. And I think it's extremely valid point that in order to, if you're doing an open surgery, in order to get to the spur, you've got to cut through the plantar fascia. Right. And that was probably exactly what was contributing, not so much the fact that you'd made the x-ray look more appealing.
Right. Yeah, no, so they got better in spite of what we were doing at that time, not because of what we were doing, Yeah. So, yeah, no, it's fantastic. I think anybody that starts to dive down the deep rabbit hole of chronic complex heel pain, it's hard to get out of that because there are so many people running around that they just have these multiple etiology heel pain syndromes. I think you made a great point that it's not always just one thing. I mean, it could be fascial degeneration. It could be osteology of the calcaneus, gait disturbances, fat pad, obviously nerve issues. So it's far more complex than a lot of people, I think, really appreciate. And the more you learn, the more there is that that you just don't know.
I know. I feel like I'm just scratching the surface, to be honest. Like the more I practice, the more you realize how little we understand as a whole about these. And I think as well, a really interesting point is if we look at a lot of the research, these patients that we see often are the exclusion criteria. If you think about your typical patient that comes in with, say, some neuritis of their medial calcaneal nerve or some distal tarsal tunnel syndrome or something like that, these patients are specifically excluded from the large trials. So these patients that are presenting to our practice that have a more complex etiology, they're the ones that aren't necessarily represented in the literature base. Right. And the difficulty is that when you take and I like to be I take an approach where I want to be informed by the research, I want to be informed by the literature, and I want to make decisions based on that. But I don't treat patients in an evidence-based approach where I'm purely treating them on an algorithm that's been determined by, a meta-analysis on heel pain. Because as much as we would love to protocolize all of our treatment approaches, it helps a number of patients, but there is, I think, always about a 20% of these patients who don't neatly fit into that presentation. And that 20% of patients is often the demographic that's excluded from the research trials in the exclusion criteria. So they're not always represented and they're not always, so it can be difficult to take the average and apply it to your individual patient that's coming into the door.
No, I think that's a valid point. And when you look at the literature, 90% of all of the medical literature is just nonsense when it comes to this because they don't even look at it. They don't even know what the plantar fascia is because they never looked at it with sonography or an MRI, but yet they want to put people into these arms. Okay, this is the steroid arm, this is the PRP arm, and they come out and they make this bold statement that X is better than Y. And it's like, no, you don't really know that because you don't know how big the fiber was in that group versus how big the fiber was in this group. So it's just, it's ludicrous. It's ridiculous. And why would you do any controlled trial for heel pain without really knowing what you're dealing with from a pathology standpoint? i.e. you have to ultrasound or at least get MRIs. But if you look at the literature, very few of them actually have done it. Now, there are a couple of good studies out there where they've done MRIs on everybody and they've done, ultrasonography on people, but those are few and far between.
They are. And I think in general, medicine and healthcare has a huge issue with the replication crisis in the literature base. A lot of the research that's out there will not be replicated if it's redone by a different set of researchers. So we've got a lot of poor quality research out there. And like you said as well, I think it's really funny when you look at when they're producing the two groups that they want to study. It's primarily around things like age, gender, BMI, things like that, but it's not related to any of the clinical findings.
Right.
So the difficulty, that you would say would be a more important aspect to it. But I can understand, because it obviously increases the complexity of your study. It increases the complexity of the analysis. It's difficult to do because these are categories that we've created. They're not necessarily categories that the human body follows.
Right.
So there is just complexity in it.
No, there's huge complexity. James, man, I could talk to you about heel pain until we'd run out of your tomorrow and our today. But I want to thank you for coming on, and
been a pleasure.
It's always fantastic to learn from you and see the quality of work that you're doing, and I really appreciate it.
I appreciate it as well. It's always enjoyable to talk, and as I said, I enjoy listening to the content that you're putting out. You've got some great guests on there, and there's a lot of insights, a lot of things that have changed my perspective. It's good to hear, and I think I find as well when I actually quite rarely go to podiatry conferences. I typically go to other professions conferences because podiatrists or physiotherapists or doctors, we tend to see the world through our own lens. And it's good to go and actually sit in someone else's conference and get a different perspective, because they see the same problem through a different lens, and you always pick up something. You get
a little bit of a different perspective, and then all of a sudden that can be a nugget to help you get a better patient outcome.
Yep, definitely.
All right. Well, what are we going to talk about the next time you come back to the show? Think about something good.
We will. Fantastic.
All right. Thanks, James. Appreciate it.
Thanks, Stephen. See you later.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at SavantCellars.com. That is CEVANT Cellars.com. Spelunk15.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.